Good morning, everyone, and thanks for the kind invitation to your Congress. We talk about the osteoporosis in arthritis with a special focus in rheumatoid arthritis. It is well known that rheumatoid arthritis is a complex disease characterized by genetic susceptibility, environmental challenges, followed by loss of immune tolerance, and a symptomatic autoimmunity characterized by stimulation, activation of T cells and antibody production, followed by the clinical feature characterized by bone loss, pain, inflammation, and erosion. We do know that rheumatoid arthritis does not only involve the local bone tissue, but is a systemic disease. And in this regard, rheumatoid arthritis is a systemic disease, may also involve a general bone mineral density loss. We know that the reduced bone mineral density is assessed in patients suffering from rheumatoid arthritis, and we know that the increased risk of vertebral fracture is well assessed. Bone loss is indeed systemic, articular, and focal. We also know that rheumatoid arthritis is a main risk factor for osteoporosis, and indeed, rheumatoid arthritis represents a risk factor included in a FRAX score. There's a concept, indeed, of a sickness behavior, the concept which was stressed and presented in 2015 by Straub and Kutolo, thus including the osteopenia and osteoporosis as a feature shared by several conditions, which are cachectic obesity, immune activation, PTH, protein hormone activation, anorexia, and so on. And it's easy to understand that also rheumatoid arthritis may be included among these features of the so-called sickness behavior. So we have a peri or articular osteoporosis, bone loss mediated by the local synovitis, and finally, a systemic osteoporosis. So we have a specific risk factor and non-specific risk factors. Among the specific rheumatoid arthritis specific risk factors, we have the ACPA positivity, the steroid treatment, the length of disease, and the secretion of pro-inflammatory cytokines. Among the cytokines, TNF-alpha has a prominent role. Indeed, the TNF-alpha may enhance osteoclastogenesis and inhibits the osteoblastogenesis through DKK1, which is the WNT inhibitor. Indeed, the serum WNT reduction inhibits the osteoblast differentiation and functionality, while conversely, TNF-alpha via NFK-BET and RANK ligando leads to an enhancement of osteoclastogenesis. Moreover, other pro-inflammatory cytokines such as interleukin-1, 6, and 17 directly stimulate RANK-L, are synergic with the TNF-alpha in the enhancement of osteoclastogenesis and negatively correlate with T-score and bone mineral density. Moreover, interleukin-6, which is normally released in physiological conditions, promotes osteoclast adhesion and promotes differentiation into T helper 17 lymphocytes, which in turn directly stimulate osteoclastogenesis. So this is the cytokine mechanism of inflammation, a cytokine mechanism leading to UXTA and UXTA periarticular and systemic bone loss in rheumatoid arthritis. So in this regard, we know that the early administration of several B-dimers and for lesser extent DMARDs may lead to reduced bone loss. The vast majority of data come from anti-TNF-alpha, which has proved the outdated but interesting study carried out by our center and reduced the periarticular bone loss in active rheumatoid arthritis. And moreover, the administration of TNF-alpha inhibitors may lead to a stabilization, even an improvement of the BMD, so the systemic osteoporosis. Moreover, this drug may lead to a reduction of serum RANK-L, the stabilization of osteoprotegerine, and an increase in osteoblastogenesis. Similarly, some studies, although performed generally in murine or in vitro models, have displayed that even tofacitinib and baricitinib, so the most novel molecules in the treatment of rheumatoid arthritis, may lead to an increase of bone mineral density. Among the other rheumatoid arthritis specific risk factors, we cannot mention the ACPA positivity. Indeed, the ACPA induces osteoclastogenesis through interleukin-8 induction, and moreover, ACPA themselves, released by activated B cells, lead to citrullination of osteoclasts. So there exists in real-life studies a negative correlation between femur BMD and ACPA titer and not factor, And a clinical trial, including up to 501 patients, displayed that AQUA represents an independent risk factor for the onset of hip fracture at 10 years. And there is a negative correlation, again, between AQUA and femur BMD. In this regard, we know that the study or retrospective study performed in our center, that the administration of rituximab, which is the drug targeting CD20, and so the B cells eventually releasing AQPA, may lead to an improvement of vertebral and preservation of femoral BND, thus suggesting a rituximab may have a bone-sparing effect due to B cell depletion. Finally, about the other conditions which are specifically related to the rheumatoid arthritis, we cannot mention the glucocorticoids treatment. Indeed, an excess of glucocorticoids leads to a reduced bone formation and an increase and enhanced bone resorption through a hyperactivation via rankel of osteoclasts, which are enhancing resorption and the survival. And we also have a reduction of the apoptosis of the osteoclasts. Finally, we have to mention the non-specific risk factors associated to rheumatoid arthritis when we have patients suffering from osteoporosis. We know that reduced BMI, female gender, smoke are commonly features which are commonly associated with osteoporosis. And in this regard, also hypovitaminosis D alone in patients suffering from rheumatoid arthritis has a paramount role. We know that vitamin D has a prominent role in the bone metabolism. Indeed, the normal values of calciferol direct activating of the maturation of the osteoblast and in the osteoblast, and then in the reduction of rankel osteoprotegerine ratio lead to a reduced resorption and increased bone formation. Thus, vitamin D and the activation of vitamin D has a prominent role in the stabilization of bone metabolism. Still, we do know that the vitamin D deficiency represents an independent risk factors in patients, in healthy patients, and and if we focus on the topic of our speech, in patients with rheumatoid arthritis. And this is a study performed in a large cohort of 2,567 Japanese patients suffering from rheumatoid arthritis, displaying an increase in fractures, osteoporotic fractures in patients suffering from hypovitaminosis B. And thus, calcium and vitamin D supplementation associated with the administration of denosumab is beneficial to enhance the bone mineral density in patients with, and especially with rheumatoid arthritis. Moreover, vitamin D has a role in inflammatory diseases, so not only directly in the bone metabolism, but also in all mechanisms eventually leading to bone damage. Indeed, vitamin D receptor is expressed by macrophages, dendritic cells, and BNT cells. Calcitriol, which is the activated form of vitamin D, plays a role in the balance between Th1 and Th2 cells, and calcitriol reduces interleukin 17 and interleukin 4, and directly acts on CD4 plus cells in promoting interleukin 10 secreting Tregs cells. So calcitriol has a role in activating not only the bone metabolism, but also in the regulation mechanisms of the immunity. Moreover, activating macrophages express a cytochrome converting vitamin D into calcitriol, which in turn stimulates macrophages proliferation. And in turn, macrophages themselves may lead to an excess of calcitriol in case of granulomatous inflammation, such as sarcoidosis and tuberculosis. So the vitamin D is a lack of vitamin D, and moreover, the certain polymorphisms of vitamin D receptor are associated with an increased risk of developing RA, and the vitamin D deficiency has been associated with several other autoimmune diseases, which is an association which is burdened, I have to mention, by conflicting data. Anyway, the data about rheumatoid arthritis are quite strong. Indeed, the low levels of vitamin D are associated with more active, more severe disease, with a higher progression of this condition in terms of local and systemic severity of rheumatoid arthritis. Anyway, the meta-analysis I'm showing you include several studies which are quite heterogeneous, so we cannot draw a firm line, and we are not able to sentence that rheumatoid arthritis is direct role and vitamin D deficiency has a causative effect in terms of severity with rheumatoid arthritis. Nevertheless, effect is assessed. Similarly, an increase in supplementation of vitamin D seems to be associated with a reduction of tender joint count, but not in pain VAS. It's not only the local activity of rheumatoid arthritis. I was also talking about the systemic effect of vitamin D. Indeed, we know that if vitamin D deficiency is associated with a more severe disease progression, we also know that there exists a negative correlation between serum vitamin D and insulin resistance and vitamin D and the disease activity. There are some common mechanisms which are able to link the rheumatoid arthritis activation and the rheumatoid arthritis activity and the cardiovascular health, because vitamin D deficiency is associated with the cardiovascular risk, because vitamin D regulates blood pressure with an action on endothelial cells, is associated with the higher mortality, the higher prevalence of hypertension, internal dysfunction, and myocardial infarction. That's why the question is why, and the answer is because the vitamin D deficiency may lead to an activation of renin-angiotensin-aldosterone axis in abnormal regulation of nitric oxide. Moreover, associated with an oxidative stress in this patient. So we have all I'm talking about a loss of immune tolerance, a genetic susceptibility which can be burdened by VDR polymorphism, and then an activation of the autoimmunity, still mediated by vitamin D deficiency, linked to activation of T cells and then to an antibody production, and eventually bone loss, systemic and periarticular, and the most evident clinical feature, which are characterized by pain, inflammation, and erosion. I thank you for your kind attention, and please stay safe.